Hi guys, welcome everyone. So let's continue our journey of learning diabetes. And in today's class, we are going to learn about two major complications of diabetes mellitus, that is diabetic ketoacidosis and hyperosmolar hyperglycemic state. As usual, हमारे rituals follow करते हैं. We will start with an MCQ. Of course, today it's not going to be based on what we have discussed in the previous class. थोड़ा सा अलग होगा. And then we will start learning about the DKA and HHS. So let's try to answer an MCQ. This is the question. Let us see how many of you can answer it. Which of the following is an indication for emergency administration of vitamin B12 in emergency room? Options are a chronic alcoholic with Wernicke-Korsakoff syndrome. Option B, a female with pernicious anemia. Option C, a patient with diabetic neuropathy. Option D, a patient with VIP connections. And E, none of the above. So how many of you are going to give me the right answer? Sankalp Maji, I will address that. So let us try to answer this. Which of the following is an indication for emergency administration of vitamin B12 in the emergency room? A chronic alcoholic with Wernicke-Korsakoff syndrome, female with pernicious anemia, patient with diabetic neuropathy, patient with VIP connections, and none of the above. So what do you think should be the answer here? Sankalp, we have not yet gone to the brain death. So as we take up that video, we will be able to understand the criteria as well. Okay, I'm waiting for your answer. Which is an indication for emergency administration of the vitamin B12? Okay, so guys, please remember there is no indication for emergency administration of vitamin B12, right? If it is a pernicious anemia, there is no need to administer it as an emergency in the emergency room. There's one important reason why am I putting up this MCQ. Why? Because please remember there was a recent incident where doctors were humiliated for not administering the vitamin B12 in the emergency room. So as doctors, we have to maintain the sanctity of spaces. Emergency room is an extremely critical part of the hospital system where patients are not supposed to walk in and ask for some cosmetics prescription or vitamin injections or even a paracetamol prescription. As doctors, we have to put our foot down and stand for our colleagues and make sure that emergency room services are available for the most deserving emergency patients, right? So the take-home message here is, please understand that there is no indication for emergency administration of vitamin B12, especially in the emergency room. Anemia, you can give it tomorrow, day after tomorrow, nothing will happen, right? Then Wernicke-Korsakoff syndrome, we need to give thiamine, not B12. Diabetic neuropathy, we do administer, but again, if I give injection now, he's not going to come out of the diabetic neuropathy immediately. And of course, not for the VIP connections, right? So none of the above should be the answer. Okay, so let's begin with the serious topic today. We're going to talk about the diabetic ketoacidosis and hyperosmolar hyperglycemic state. So we classify them under the acute complications of diabetes. So there are three major acute complications of diabetes. The first one is diabetic ketoacidosis. Diabetic ketoacidosis or DKA. For the university exams, this is a repeatedly asked 10-mark question. The second one, closely related condition with some differences, we will call it as hyperosmolar state. Hyperosmolar state. And the third one is hypoglycemia. Need not always be because of diabetes, but the complication of diabetes treatment. When we give insulin or other sulfonylureas, they can end up with hypoglycemia, right? So these are the three major acute complications of diabetes. Every doctor should know how to manage these three complications. So today we will concentrate on diabetic ketoacidosis and hyperglycemic hyperosmolar state or HHS. Okay, so what we will do is we will first try to understand why DKA and HHS develop. What is the key pathogenic process? In the diabetic ketoacidosis, there is absolute insulin deficiency. Absolute insulin deficiency. So if you have severe diabetes and your insulin production is close to nil, you can end up with diabetic ketoacidosis. Now, with this information, can anybody tell me which type of diabetes is more likely to be prone to develop DKA? Is it type 1 or type 2? Type 1 or type 2? Which one is more likely to develop DKA when there is absolute insulin deficiency? Body is not making any insulin. Which condition body is not making any insulin? In HHS, the main pathological process is triggered by relative insulin deficiency. Means जितना इंसुलिन चाहिए बॉडी को उतना तो नहीं मिल रहा है, बट थोड़ा बहुत मिल रहा है. जितना चाहिए उतना नहीं मिल रहा है. But in case of DKA, there is no insulin production at all, right? So there is relative insulin deficiency in case of HHS. Yes, DKA is more common in type 1 diabetic patients. Okay. So now what happens when I have absolute insulin deficiency and relative insulin deficiency? Why am I ending up with these complications, right? Let us try to understand the pathogenesis. Let us first look at the DKA. There is absolute insulin deficiency. Now, what is the main function of insulin? I've told you in the very first class, right? Whenever a teacher asks you what is the main function of insulin, please do not say, sir, regulation of blood glucose levels. Yes, it is indeed an important function of the insulin, but equally important is that insulin is required for the cellular utilization of glucose. Cells are able to utilize glucose only when insulin is there. Otherwise, cells cannot use the glucose. So when there is absolute insulin deficiency, there will be decreased cellular glucose uptake. Cellular glucose uptake. So cells are not getting sufficient glucose. Second, one more thing we discussed. If blood glucose level decreases, there is a counter regulatory hormone which tends to increase the blood glucose level back to normal range. कौन सा है? Mainly glucagon, and there are some accessory counter regulatory hormones like cortisol, right? They will also help you to adrenaline. They will also help you to increase your blood glucose level when it is going low. So when we were talking about the drugs in the previous class, I told you that insulin and insulin secretagogues cause hypoglycemia because they suppress counter regulatory hormones. Insulin suppresses the release of glucagon. But now that there is absolute insulin deficiency, glucagon kya hoga? There is no more suppression of the glucagon. So glucagon will increase. So there will be increased counter regulatory hormones. Increased counter regulatory hormones. The main counter regulatory hormone is, of course, the glucagon. Apart from that, cortisol. That's why whenever someone takes steroids, their blood glucose level tends to increase. And the other one is adrenaline. So they all increase. And when they increase, what it will lead to? They will stimulate proteolysis. So we start breaking down the protein. It will start causing proteolysis. And second one, it will stimulate, increase the lipolysis. We start breaking down the fat, lipolysis. Now, all these factors, decreased cellular uptake and increased lipolysis and the proteolysis, will contribute to increase in the blood glucose level. Okay. So this will contribute to increased blood glucose levels. Now what this increased blood glucose levels will do? There will be glucosuria. We'll start excreting glucose in urine because blood glucose level is high. So I start excreting it in urine. But as we already know, glucose being an osmotically active substance, it will take water along with that. So I will end up with polyuria. This polyuria will trigger increased thirst. So I will also get polydipsia. But here I am losing so much water that I may become dehydrated. I may become severely dehydrated. Now this dehydration can be severe enough to literally kill the person. It can cause hypotension and death. So that is one fear I have when I have a patient with diabetic ketoacidosis. Why did I land up with dehydration? Because increased blood glucose level triggered me to lose more water in the urine, resulting in dehydration. Okay. Next. Now that there is decreased cellular uptake of glucose, cells are no longer dependent on glucose for metabolism because they can't get the glucose because insulin is not there. So glucose won't enter the cell. So now from where the cells should derive energy, that shifts, right? So that shifts metabolic drive to, from lipolysis we get free fatty acids, and free fatty acids now become the primary source of energy. Because in normal condition, what is the primary source of energy for cells? It is glucose, right? But here, because cells are not able to use the glucose, now free fatty acids become the primary source of energy, primary energy source for the cells. Now what is the problem that this leads to? The free fatty acids will be inadequately metabolized, resulting in formation of what we call as ketones or ketone bodies, like beta hydroxybutyrate, acetone. So there will be formation of ketones. Now these ketones are acidic. So to buffer that, ketones being acidic, to buffer that, body has to use the base, that is bicarbonate. So this results in utilization of bicarbonate. So there will be depletion of the bicarbonate. Once bicarbonate fails to regulate, like see, there is rise in acid, more and more ketones being produced, these are acids. Now to neutralize this, I have to use the base. So base starts decreasing. Somehow decreasing base keeps the pH in normal range, but once the base gets further depleted, I will not be able to maintain the pH in the normal range, and now I end up with acidosis. What type of acidosis this is? We will call it as metabolic acidosis, because it is not because of the respiratory system dysfunction. We are ending up with metabolic acidosis. So two major things happened here. One, increased blood glucose level resulted in dehydration, and second, I ended up with metabolic acidosis because of the formation of ketone bodies. Why ketone bodies formed? Because now I have to shift the cellular metabolism from glucose as the main energy source to free fatty acids as the primary energy source. Clear? Now, what other complications this is going to lead to? As I develop this metabolic acidosis, right? Metabolic acidosis, under that low pH, cellular metabolism gets further deranged, cardiac contraction can come down. Couple that with the dehydration, I can develop hypotension, shock, and I can die. So there is increased risk of death in patients with diabetic ketoacidosis. So what is the take home message? This all started with absolute insulin deficiency. Now what is this other condition called as hyperosmolar hyperglycemic state? HHS. How is it different? HSS is typically more common in type 2 diabetes mellitus patient, where main pathology is insulin resistance. So body is not getting as much insulin as it wants, but not zero, right? So there is relative insulin deficiency. जब insulin कम होगा, counter regulatory hormones will increase. It will cause lipolysis and proteolysis, just like DKA. There will be formation of free fatty acids, but these are not going to be my main source of energy. The main source of energy will still be glucose. With relative insulin deficiency, there is decreased cellular uptake of glucose, but that is sufficient. There is still sufficient insulin to keep glucose as the primary energy source. So because of this, because glucose continues to be the primary energy source, there is no formation of ketones. And if there is no formation of ketones, there will be no acidosis. So if no ketones, no acidosis. So this is the main difference between diabetic ketoacidosis and HHS. In DKA, the energy metabolism has switched to free fatty acids as the main source, resulting in ketone formation and acidosis. Here, there is still some amount of insulin, काफी है to keep glucose as the primary energy source, and thus I do not use too much of free fatty acids, so I don't generate too much ketones. I don't end up with acidosis. Okay. On the other side, the other complication that we discussed, increase in the blood glucose level resulting in polyuria and severe dehydration, that happens here also. So DKA as well as HHS are associated with severe dehydration, but in DKA there is acidosis, in HHS there is no acidosis. Now based on this understanding, can anybody tell me which one is a more severe condition? DKA ज़्यादा severe condition है या HHS? और death risk कहाँ पे ज़्यादा है? Is it in DKA or is it in HHS? Where is the higher risk of death? In DKA or HHS? So this is DKA, acidosis है. HHS में there is no acidosis. So where is the high risk of death. Okay, I'll come to that point. First, we will understand the clinical features of DKA. The first common clinical feature is patient will have polyuria and polydipsia. Polyuria and polydipsia, increased urination and increased thirst. Second, he will have severe dehydration and all the signs of severe dehydration like sunken eyeballs, decreased skin turgor. Third, he may have hypotension because of severe dehydration, because our blood pressure depends on the circulating blood volume. Okay. Fourth, there is increased production of ketones, right? So these ketones are giving fruity smell. Anand Hospital, very good, very good. They will give fruity smell to the patient's breath because they are volatile. They will be exhaled in the air, in the breath. So it gives fruity breath odor due to presence of ketones, or mainly the acetone, one of the ketone bodies in patient's breath. In patient's breath. Fifth, when I ended up with acidosis in DKA, that is metabolic, will there be a compensatory change? As the acid level starts building up, the respiratory system has to drive out more carbon dioxide. So to drive out more carbon dioxide, the respiratory rate increases. So there will be a labored breathing with increased respiratory rate. We call this condition as either acidotic breathing, or you can also call it as Kussmaul's breathing. It will be called as acidotic breathing or Kussmaul's breathing. This is basically a respiratory system's compensatory mechanism. Respiratory system is just trying to wash out the carbon dioxide to keep the pH balanced. So these are the clinical features. In HHS, what clinical feature will be missing? In HHS, the fruity breath odor and the acidotic breathing or Kussmaul's breathing will be missing. Otherwise, hypotension, severe dehydration, polyuria, polydipsia can happen in HHS as well. Now, regarding which one is more severe, please remember the death risk is higher in patients with HHS. आप पूछोगे सर यहाँ पे तो acidosis है, there should be higher risk of death. Why is it more in HHS? The reason for that is these symptoms, this acidotic breathing, tachypnea, makes patients quite uncomfortable. So they present to the hospital early. But in patients with the HHS, because these acidotic symptoms are not there, they present to the hospital late. जब बहुत ज़्यादा dehydration हो चुका होगा और बहुत ज़्यादा BP drop हो चुका होगा, they come at that stage. That's why the HHS carries higher mortality. DKA patients, because of the symptoms of acidosis, they present early. So that thus it carries lower mortality, right? So we'll put a table. This is where MCQs are asked routinely. So we'll try to compare the differences between DKA and HHS. So when I get a patient with DKA, the usual blood glucose level varies from 250 to 600 milligrams per deciliter. In this range, they present to the hospital. But the HHS patients usually present after their blood glucose level is crossed more than 600 milligrams per deciliter. Why? Because these patients develop acidotic symptoms, they present early. These patients don't develop acidotic symptoms, so they present late. Okay. The plasma ketones will be detectable or positive in DKA patients. They are generally absent in HHS patients. When I look at the pH of the blood, arterial blood gas analysis pH, in diabetic ketoacidosis, there is metabolic acidosis. So the pH will be less than 7.3 generally. In case of HHS, it will be more than 7.3. There is not much of acidosis present. Now, when there is metabolic acidosis, we classify metabolic acidosis into high anion gap and non-anion gap metabolic acidosis. तो यहाँ पे किस तरीके का metabolic acidosis होगा? High anion gap metabolic acidosis comes into picture when an extraneous or extra acid is added to the body. So in DKA, what happens? We are adding an extra acid, not the normal physiological acid. An extra acid is being added, that is the ketone bodies. So when I'm adding an extra acid, I'm creating an anion gap. So we will have a high anion gap metabolic acidosis. So whatever we discussed here as metabolic acidosis will be high anion gap metabolic acidosis. This will be high anion gap metabolic acidosis. So when do we call it as high anion gap metabolic acidosis? जब ये anion gap is more than 12. Anion gap is more than 12. Now the main part, I was telling you repeatedly that this HHS carries worse prognosis, higher death risk. Kyun? Because they present late. So by the time they present, they would have lost more than 9 liters of fluid from the body already through polyuria. So they will be in much more profound dehydration. So when I get a patient with DKA, he might have lost around 4 to 6 liters of fluid from the body. So he is at lesser fluid deficit than this HHS patient. So that is why patients with HHS carry poor prognosis than diabetic ketoacidosis. Okay. Now, in which type of diabetes DKA is more common? DKA is more common in type 1 than type 2. Why? Because for DKA to happen, I need to have absolute insulin deficiency, which happens in more advanced stages of type 2 diabetes mellitus where beta cell is significantly depleted. But type 1 mein, in the beginning only I can provide that condition. So that is why DKA is more common in type 1. HHS is typically more common in type 2 diabetes mellitus. Type 2 diabetes mellitus. One extra point important for the exam is that in India, our Indian population, particularly the type 2 diabetes mellitus population, is more prone to develop DKA than the rest of the world. For some unknown reasons, Indian population is more prone to develop diabetic ketoacidosis, type 2 diabetes I'm talking about, than the rest of the world. So that's why we often, if you go to your wards or hospitals, you often see patients with DKA in India. You may not be seeing so many DKA patients in the rest of the world because in them, it is mainly type 1 diabetes, but in India, type 2 also often present with DKA, right? So if they ask you which one carries poor prognosis, it is the HHS which carries the poor prognosis. Simple reason, they present late because they don't have the acidotic symptoms. So they present late to the hospital. By the time they have presented, sugars are quite high. They have lost so much of fluid and they generally end up in hypotension or shock. Okay. Now that we know the basics, we will talk about the management of diabetic ketoacidosis. So there are multiple areas that we need to address. The first one is that patients are generally in fluid deficit. That fluid needs to be corrected. Second, their blood glucose level will be high. Hyperglycemia needs to be corrected. Third, this hyperglycemia and insulin deficiency might have triggered some electrolyte abnormalities, mainly potassium abnormalities that needs to be corrected. And last but not the least, the acidosis, if required, needs to be corrected. So these are the 4 areas that we need to address to manage a case of DKA. If you ask me, sir, what is the most important or the first step in management of diabetic ketoacidosis, right? This is it. The fluid deficit management is the most important step in the management of DKA. Why? Because they have lost. See, look at this. They would have lost 4 to 6 liters of body fluids. These people would have lost 9 liters of body fluid. So they are pretty prone to develop hypotension, shock, collapse, and die. So if you want to save them, first thing is that you have to fill this fluid deficit. After that, control the glucose and rest of the problems will get sorted. So primary and the most important step is correction of fluid deficit. Repeatedly, NEET PG, INI-CET, they keep asking, they give the story, blood glucose itna hai, BP itna hai, all the parameters. By looking at this, ketone body is positive and all, you come to the conclusion that question mein DKA ki baat ho rahi hai, the question is talking about DKA. And then many students, despite repeatedly teachers telling that the most important and the first step is to correct the fluid deficit, you end up answering giving the insulin, right? That's not the first step. Okay, so first we will address how do I manage fluid deficit in DKA. So because they have 4 to 6 liters of fluid deficit and HHS almost 9 liter, I have to at least load some amount of fluid immediately, right? So that is why initial fluid management is very, very crucial. So we have to give around 15 to 20 ml per kg per hour IV 0.9% or normal saline for 1 to 2 hours. For 1 to 2 hours. In my setup, I generally give for 2 hours. Now, this is very, very crucial because if you become an intern, before your PG comes into picture and manages the case further, at least initial fluid you should know, right? Kitna dena hai. So how do I get to know? Information is here. Let us say that I'm talking about a 50 kg person. What should be the initial fluid that I'm going to give? Let us take the higher number, 20 ml per kg per hour for first 2 hours. So 20 ml per kg for a 50 kg person will be 50 kg into 20 ml, that transforms to 1 liter. So first 1 ghante mein I need to give 1 liter of fluid, that is again 0.9% sodium chloride or normal saline, and then second hour also I will give 1 liter of fluid. So 2 liter of fluid हुआ. So he had the deficit of 4 to 6 liters. उसमें से मैंने 2 liter already replace कर दिया है in the first 2 hours, right? So that is how we make the initial fluid. But once I have given the initial fluid, I need to continue giving the fluid till all the deficit is filled. Whatever 4, 6 liters, 9 liters he has lost, सब वापस आना चाहिए. But अब हरी नहीं है. Initially बस 1 to 2 liters or whatever calculation this statement gives, उतना first 2 hours में load करना है. After that, further fluid will be based on कि हम ये normal saline ही continue करेंगे या नहीं. Whether I will continue the same normal saline or not depends on patient's serum sodium. So once I get the patient's serum sodium, if it is normal or increased, serum sodium is in the normal range or increased, in that case I will switch to 0.45% sodium chloride or half normal saline. But if the serum sodium is low, then we will continue with 0.9% sodium chloride. Now infusion rate क्या होगा, how much per hour I should give, that depends on various factors. At that, after the initial loading, patient का hydration status क्या है, urine output क्या है, and there are other like invasive and non-invasive ways of monitoring the hydration. Based on that, we will decide. For the exam, if you are able to write this point, it's more than enough. But this is something that you should know, whether you are writing for exam or practice. At least initial management you should be able to do. So you are giving normal saline 20 ml per kg per hour for first 2 hours, right? After that, maintenance fluid. Now that was about fluid management. The next thing is the management of potassium. Usually patients with DKA may have normal or high potassium at the time of presentation. Whether it looks at normal in the blood or whether it looks to be high in the blood, depending on the blood value, still their total body potassium will be depleted. In the absolute insulin deficiency, their total body potassium will be reduced. So that's why I have to think about giving the potassium also. So there are parameters to look at. If the serum potassium level is less than 3.3, should I give insulin to this patient when the serum potassium is less than 3.3? When the serum potassium is less than 3.3, hold insulin. Do not give insulin. Why? Because insulin worsens hypokalemia. Insulin facilitates the entry of extracellular compartment potassium to intracellular. So blood का potassium और भी कम हो जाएगा. It will decrease further. And at very low potassium levels, patient can develop various complications, including the cardiac arrhythmias as well as decreased gastric motility, right? It can lead to the paralysis of intestinal movement. So we have to hold insulin and I have to correct this potassium, correct K plus to more than 3.3 milliequivalents per liter. There are formulas to calculate how much is the total deficit. उसके हिसाब से calculate करके we have to give the potassium, and till potassium comes to more than 3.3, do not give insulin. But if it is in the range of 3.3 to 5.2, then we have to give insulin as well as the potassium when it is 3.3 to 5.2, because I have already told you their total body potassium is decreased. It's not normal, even if their blood value appears to be normal. So I have to keep giving them potassium to fill that total body deficit. तो कितना देंगे हम? Generally 20 to 40 milli equivalents of potassium added to per liter of fluid. So every 1 liter of fluid, we are going to add 20 to 40 milliequivalents of potassium. Fluid that is going to be whether normal saline or half normal saline depending on the circumstance, but उस fluid में हर एक लीटर में हम 20 to 40 milliequivalents या हर आधे लीटर में 20 milliequivalents potassium add करते जाएंगे. Okay, and if the potassium is more than 5.2 at this point of time, I don't need to give potassium because it's already on the higher side in the blood. So in that case, we should not give, do not give potassium. Continue with fluids and insulin. Continue with fluids and insulin. So this is the protocol that we are going to follow for the potassium, right? If it is low, do not give insulin. If it is high, do not give potassium. If it is in the fairly normal range, continue with insulin, give fluids, but add potassium to the fluids. Okay, so that's about the potassium management. This is fluid management. This is potassium management. Now comes the main part. Until and unless I correct the hyperglycemia, patient will continue to have polyuria. Whatever fluid I give, he will excrete that also in urine. He will get back to the state that he started with. So I have to also parallelly address hyperglycemia. So when I have to address hyperglycemia, first I have to give some loading dose or bolus insulin. Which insulin we are using? Preferably we are using regular insulin. If regular is not available, which is generally available, you can use some short acting insulins. Okay, so we are using 0.1 unit of insulin per kg as IV infusion. 0.1 unit of insulin per kg as IV bolus. This is first step. So let us take the example. If I am dealing with a 50 kg person, how much should be the insulin initial bolus when I have recognized that a patient has got diabetic ketoacidosis? Multiply 50 into 0.1. So how much I get? 5 units. So I'm going to give 5 units of regular insulin IV as a bolus. Just push it. Once I'm done with that, that will give me some initial drop in the blood glucose level, right? But if I don't, because it's regular given IV, it's going to act for a very short period of time. Again, the blood glucose level will bounce back because patient's body is not producing insulin. He is in absolute insulin deficiency. So till I achieve a reasonable amount of decrease in the blood glucose levels, I need to keep giving insulin. So we'll follow a continuous insulin infusion. Continuous insulin infusion of, again, same value, 0.1 unit per kg per hour. So that I gave initially 5 units of IV bolus. After that, I will start insulin infusion at, for this patient, 5 units per hour. Because he is 50 kg, 0.1 unit per kg per hour. So 5 units per hour insulin infusion I will start. Once I start the insulin infusion, I have to monitor the blood glucose level every hourly. Hourly blood glucose level should be monitored. If you are in a resource limited setting or in a periphery where hourly monitoring is difficult, then you can monitor it every 2 hours, right? Hourly blood glucose monitoring should be done. Now, should I just continue with 5 units of insulin for this 50 kg person? No. I have a target goal. What is the goal? The glucose should decrease by 50 to 75 milligrams per deciliter per hour. So every hour I check, the glucose should lower by what, like let us say initial value tha 350. I gave 5 unit bolus and then I started 5 unit infusion. I check after 1 hour and 1 hour के बाद मुझे कितना value मिलना चाहिए? At least 50 milligrams per deciliter decrease, right? So if let us say it has become 290, fair. So I am on the right track, right? It has decreased by 60. So I am on the right track. I can continue the same insulin infusion dose. 5 units start kiya tha, 5 unit I can continue. But let us say another circumstance where it has become 320. So at this point of time, the decrease is not as per our target goal. So in that case, I have to increase the insulin infusion. From 5 units, I can go up to, like I can increase by 2 or 4 units more. Okay. On the other hand, let us say I got one more circumstance where it has dropped from 350, it has come down to 210, which is more than 75 milligrams per deciliter drop. 350 to 210 is almost 140. So this is too drastic decrease in the insulin. So in that case, what should I do? I have to decrease the insulin infusion rate. I was giving 5 units per hour. Now I have to step down to 3 units or lower, depending on how drastically the values dropped. Yeah, we have to dilute the insulin in the IV fluids. So when we are initially starting, we are starting it in the 0. Say we have already decided which fluid to use, right? So we are starting with a normal saline or half normal saline, depending on the circumstance. Of course, हम dilution calculate कर सकते हैं, right? Like for example, मेरा infusion rate है. Let us say मेरा infusion rate है 100 ml per hour मैं infusion दे रहा हूँ, and I want to give 5 units of insulin. Then what I should do? I should add 50 units of insulin for 1 liter of the IV fluid, or 25 units of insulin in 500 ml of IV fluid. So most of the hospitals, what we do is, because the maintenance fluid that we are giving, uska rate हम ऊपर नीचे करते रहेंगे depending on urine output, blood pressure and other parameters. तो हम एक parallelly separate insulin infusion start करते हैं, right? We start a separate insulin infusion, and that fluid we do not want to overburden like extra fluid, क्योंकि हाँ already हम 250 ml 300 ml per hour के हिसाब से fluid हम शायद दे रहे होंगे. So there we can keep it more concentrated. Like we can easily make a insulin concentration of, like, let us say that if I want to achieve a concentration of 5 units for 10 ml, then how will I make? I will add 50 units in 100 ml of normal saline. So in that case, it will be 5 units per 10 ml. अगर आपका infusion देना है 5 units per hour, then you should set it at 10 ml per hour. If you want to give the infusion, let us say at 7 units per hour, then in that case, accordingly, you have to increase or decrease the flow rate. Okay, so once I have started this insulin infusion and I am on the right track as expected, 50 to 75 milligrams per deciliter के हिसाब से the blood glucose level is dropping. Good, you can continue. Till what? Till you reach the blood glucose value of less than 200 milligrams per deciliter. Once you hit the blood glucose value lower than 200 milligrams per deciliter, we need to do two things. One, जो भी insulin infusion चल रहा है उसे रोक दो. Second, जो भी fluid चल रहा है, normal saline, half normal saline, whatever you are using, stop it, because now the pathology is largely addressed. The things are getting towards the physiology. So now I have to switch the fluid to either DNS, or if I'm continuing with the normal saline, then I have to add 5% dextrose to the fluid, because if I continue, see, if I stop insulin, what is the problem? They are in absolute insulin deficiency. मैंने insulin stop किया तो सारा pathology फिर से वापस आएगा, right? Again, there will be patient will get pushed towards the free fatty acids as the main source of energy, ketone body formation, everything will come back. So I can't do that, right? But if I continue to give the insulin infusion at the same dose, he will go into hypoglycemia, right? So now what I should do, once it is less than 200, I will reduce the insulin infusion rate to 0.02 to 0.5 units per kg per hour. And second, to support the cells with glucose, we also need to add 5% dextrose to the fluid. Don't worry, this will not push their blood glucose level very high, because we are still giving the insulin. This will help the cells utilize this glucose, because हमने fatty acid as a source of energy को रोकने की कोशिश की है, but at the same time I also need to provide glucose for the cells to use as a source of energy. Okay, so this is about the blood glucose management and insulin in case of diabetic ketoacidosis. So among the areas of concern, we have already addressed how to manage fluid deficit. Around 20 ml per kg per hour should be the initial fluid loading for first 2 hours. Then for hyperglycemia, we start insulin infusion at 0.1 units. First, we give a bolus of 0.1 unit per kg, and then insulin infusion at 0.1 unit per kg per hour with a target glucose lowering of 50 to 75 milligrams per deciliter per hour. Once we reach less than 200, we stop this approach. We switch to adding 5% dextrose or dextrose normal saline, and along with that, we give a smaller dose of insulin infusion to keep the blood glucose level normalized. Electrolyte abnormalities, potassium based on the patient's potassium value. If it is less than 3.3, first thing is to correct the hypokalemia and then only start insulin. But if it is in the normal range, 3.3 to 5.2, we can keep giving insulin fluid and potassium. And if it is more than 5.2, there is no need to give potassium. And now the only pending thing is, how do I address that acidosis? The pH jo kam hua hai, how do I correct it, right? So how do I correct the pH? So the thing to note here is that insulin corrects pH by correcting cellular metabolism. Cellular metabolism. So I specifically do not generally need to give some bicarbonate to correct the pH, because see, look at this pathophysiology. It all started with insulin deficiency. So if I start giving insulin, this is stopped. So once I start giving insulin, cells will start taking up the glucose, right? So as the cells start taking up the glucose, my dependence on free fatty acids as a primary source of energy will come down. So I will not produce much more ketones. So my bicarbonate utilization will come down and this metabolic acidosis will get reversed by itself. So I generally don't need to address the acidosis part of the DKA, but if the pH is less than 6.9, it can lead to life-threatening hypotension. Life-threatening hypotension. Chandan Patra, the fluid rate is calculated based on the patient's current status of hydration. So fluid rate हमेशा patient के hydration status के हिसाब से हम modulate करेंगे. There is no fixed rate for any fluid as such. Only initial loading is a calculated one. After that hydration status के हिसाब से हम adjust करते जाएंगे. But if the pH is less than 6.9, that can lead to life-threatening hypotension, because at such pH, cardiac metabolism becomes severely affected. So in that case, I need to give bicarbonate. IV bicarbonate only if pH is less than 6.9. 7, 7.1, 7.2, 7.3, you don't have to correct it. Just take care of the hydration and the blood glucose levels and the acidosis will get corrected by itself. Okay. Now I know how to manage, right? 4 areas: fluid deficit, hyperglycemia, potassium and acidosis. But when do I call off the treatment? Because for the fluid management, we started some fluid and we are giving that maintenance, right? Based on hydration status, हम देते जा रहे हैं. Similarly, we are giving insulin infusion. So there should be some point where I can stop the infusion and switch to subcutaneous insulin. There should be some point where I can stop giving the IV fluids and switch to oral fluid intake. So when can I do that? When can I do that? Chandan Patra, again, the bicarbonate dose will be calculated based on the bicarbonate deficit. So like there are some areas where as we go forward and start taking up other systems, we will be getting into the more details of it. For now, let us build the basics first. Okay. So when do I decide that I can now say that DKA is resolved and all this protocol can be called off and I can switch to less aggressive means of management like subcutaneous insulin, oral fluids? So we'll say DKA is resolved when the blood glucose value has come down to less than 250 milligrams per deciliter. pH has become more than 7.3. The bicarbonate value has become more than 15 millimoles per liter, and the anion gap has come down to normal anion gap range, that is less than 12. So when these parameters are achieved, we can say that DKA is resolved and then we can step down on the treatment. And that's why, again, an important point I probably missed while talking about the DKA. There's a well laid out diagnostic criteria for the DKA. What is the diagnostic criteria for DKA? This is something that during your ward rounds, your professors often ask, what is the diagnostic criteria for DKA? So I will diagnose diabetic ketoacidosis when these following criteria are met. The first one, the blood glucose should be more than 250 milligrams per deciliter, right? If DKA occurs with blood glucose level less than 250 milligrams per deciliter, we call that condition as, this will be called as euglycemic decay or euglycemic ketosis. It is usually a side effect of a class of drugs. Which class of drugs? This is usually a side effect of SGLT2 inhibitors. It's a side effect of SGLT2 inhibitors. This we have discussed in the previous class as well, right? Second, the blood pH, to call it as acidosis, should be less than 7.3, and this acidosis has to have high anion gap, so anion gap should be more than 12. And the fourth one, their serum bicarbonate values should be less than 18. So when these parameters are met, we can, the fifth one I forgot to mention, the plasma ketone bodies, plasma or urine ketones should be positive. Urine ketones, ideally plasma, but urine ketone positive also can be taken as the criteria. So when these criteria are met, we call it as diabetic ketoacidosis. The first criteria, missing blood glucose level, let us say 180, and all other features are there, then we call it as euglycemic decay, typically more common in the SGLT2 in patients who are on SGLT2 inhibitors. So this criteria for resolution is based on the criteria for diagnosis, right? Like when you look at this, the criteria for resolution is blood glucose level more than 250 was a diagnostic criteria, less than 250 is resolution. pH less than 7.3 was a diagnostic criteria, more than 7.3 resolution. Bicarbonate is supposed to be low. Now coming back to normal range, we can count it as resolution. Then anion gap was more than 12 as a criteria, it is coming back to normal, then we would say that it is resolved, right? So this is how we can conclude that DKA is resolved. Now insulin can be switched to subcutaneous, and the fluids can also be switched to oral, right? So that summarizes our management of DKA. So let us take one or two MCQs before we wind up for the day. So here's the first question. Which of the following is not a diagnostic criteria for DKA? I just discussed it, so hopefully you should be able to answer. Not a diagnostic criteria for DKA. Serum glucose more than 250, serum bicarbonate less than 18, anion gap more than 12, serum osmolality more than 350 milliosmoles per liter. Which of the following is not? Right, very good. So serum glucose was part of the criteria, serum bicarbonate was part of the criteria, anion gap was part of the criteria. Serum osmolality in DKA will be generally high. Why? Because glucose is an osmotically active substance, and the three major osmotically active substances in the blood are sodium, urea, and glucose. So any one of them increase in the blood osmolality will increase. That's why the HHS is called as hyperosmolar state, right? Hyperglycemic hyperosmolar state इसलिए कहते हैं because as glucose increases, the serum osmolality also increases. But increased serum osmolality is not part of the diagnostic criteria. Though it is seen, it is not part of the diagnostic criteria, so that becomes our answer. Okay, so let me take you through one more question. Here's the question. In a patient with DKA and serum potassium of 2.9, this is one of our INI-CET question. The next best step is, 4 options: start insulin infusion, give 1 ampoule of bicarbonate, replace potassium first, administer 0.45 saline. What should be our answer in this question? Chandan Patra, good. So many of the students generally answered option D, because whenever we talk about DKA, what do we talk about? Fluids first, right? Fluids first. But why then why D is not the answer? Let us see how will I manage this patient, right? So this is a patient with DKA and he has hypokalemia. Any patient with DKA, right? Any patient with DKA, whether with low potassium or not, first step is always fluid. But what fluid? Fluid resuscitation will be the first step. But resuscitation के लिए fluid of choice क्या है? Normal saline. How much we are giving? 15 to 20 ml per kg per hour for 1 to 2 hours. Okay. After that, we have to think of insulin. After that, we will of course switch to maintenance fluid, and then we have to think of insulin. Now insulin, there were point. If potassium is low, we should not give insulin. First thing we have to do is correct the potassium. So here in this scenario, what will be in my second step? Second step is correct hypokalemia. Correct hypokalemia. Once the potassium value comes to more than 3.2, then I go to the third step. What will be my third step? Third step is IV bolus insulin followed by infusion. Bolus insulin followed by infusion. How much bolus insulin I'm going to give? 0.1 unit per kg. So if I mention that it is a 60 kg person here, then 6 unit bolus followed by 6 unit per hour infusion. And hourly I will monitor the glucose, and till glucose level goes down to less than 200, I will continue the infusion. Rate will be adjusted depending on whether I am getting 50 to 75 millimeters per hour decrease in blood glucose level or less or more. Once the glucose value is less than 200, I stop this infusion. I start lower infusion rate, lower amount of insulin, and I add 5% dextrose to patient's fluid, right? So in this case, 0.45 will be only talked about after the initial fluid resuscitation. If the corrected sodium value is normal or high, then we start with 0.45 saline, not the initial fluid. So if they had mentioned normal saline also, I would have gone ahead with normal saline as the answer. But we use half normal saline after initial fluid loading depending on the sodium values. So now that this is not normal saline, it's half normal saline, that can't be my first choice, right? So that's not going to be my answer. So what should be the answer? Option C, replace potassium first followed by insulin, right? Followed by insulin. That is going to be our approach. Start insulin infusion? No. Bicarbonate only if we will start bicarbonate only if pH how much? Less than 6.9, less than or equal to. Insulin infusion after, in this case, after potassium has become more than 3.2. Okay. And half normal saline, we will use it for as maintenance fluid if serum sodium values are normal or high. Clear? So this is how we are going to manage the case of DKA. So please try to solve some more MCQs from the MedEd app on the DKA management. And if you have any confusions or if you have doubt like why this should be the answer, please ping me on the Telegram and I will include the explanations in the next class. So that's it from me today. And I'll see you in the next class. In the next class, we will talk about the nephropathy and the diabetic nephropathy and neuropathy. And then we will have a case of neuropathy as well. And we will run a diabetes quiz, like whatever total diabetes we have covered. Based on that, there will be a quiz. And after the quiz, we will start with another system, right? So that's it from me today. I'll see you in the next class. Till then, have a good time. Bye-bye.